Good morning. Dr. Subramony was trained in neurology and electromyography, neuromuscular diseases at the Cleveland Clinic in Cleveland, Ohio. After being on the faculty at the University of Mississippi Medical Center for almost 30 years, he has since directed the adult muscular dystrophy clinics and the ataxia clinic at the University of Florida since 2009. Over the past 25 years, he has had an investigative interest in genetically determined neuromuscular disorders and hereditary ataxias. He is focused on translational research to bring innovative therapies to these disorders. Dr. Subramony is considered one of the world's leading experts in these fields. Currently, he focuses on genetic neuromuscular diseases and ataxias and offers treatment that includes electromyography, muscle biopsy, when appropriate genetic testing, and referral to ancillary services such as physical, occupational, and speech therapy and evaluation for mobility aids. Please welcome Dr. Subramony. Hi there. Would you like this in the stand or would you like to hold it?
I'll hold it.
Okay.
Thank you very much for that very kind introduction. And let's see. So I would like to take you to a little bit of history of my own with regard to the periodic paralysis because, as was pointed out, my current translational research involves a variety of genetic neuromuscular disorders, particularly myotonic dystrophy and Friedreich's ataxia, which have a different mutational mechanism than what you see in periodic paralysis. But my interest was triggered years ago when I was a junior faculty, and I saw families with hyperkalemic periodic paralysis, paramyotonia. I tried to understand the phenotype of these disorders, did some publications. Some of the tests which I described in the 1980s are still used commonly to evaluate patients with these periodic paralysis and paramyotonia congenita, such as the exercise test, the cooling test, etc. So I was intrigued by these disorders. Unfortunately, I didn't have a large collection of patients afterwards, so did not develop those interests. Now, the history of this is very interesting as well in a larger sense. We had a little bit of the history before. In fact, the first of these disorders to be clinically described was paramyotonia congenita in 1886 by a German physician by the name of von Eulenberg. And then I cannot quite clearly say who described hypokalemic periodic paralysis. There was a name mentioned yesterday, I missed that, but in Europe, this is often called Westphal's disease, and I don't know who Westphal is. And then it was 1956 when Gamstorp, a pediatrician in, I believe, one of the Scandinavian countries, described a family with hyperkalemic periodic paralysis. Now, it turns out that serum potassium, the ability to measure it, developed in the 1930s. And I got intrigued by this last story here, elementary, my dear Dr. Allen, is because I heard of this story, a disorder in China that they call Pa Ping. And the British physicians in the 1940s in Shanghai, I believe, were seeing patients, mainly men, almost all men, who would turn up in the emergency room paralyzed and had low serum potassium. They were able to measure the potassium, and then they were able to give them potassium, make them better. Dr. Allen was a Canadian missionary physician in China at the time. He and one of his Chinese colleagues eventually came to the conclusion that these men, over the weekends, they all turned up on Saturdays. So there was a pattern to this. The men would eat out. The women did not. They would go to the theater and then eat out. And the restaurants, the salt was contaminated with barium, which was not the case at home. So chronic barium toxicity leads to chronic hypokalemia, and these patients would come in with repeated episodes of periodic paralysis. It was not genetic in nature. The local name for this disease was Paping, and Lauren Bowen was one of my medical students who researched this, actually managed to interview the niece of Dr. Allen and wrote a wonderful historical paper about this particular disease. And fortunately, I mean, one other piece of history in my own, and was that I actually missed this patient. My name is somewhere in the middle when we found the ATS gene mutation. This was a young lady with hypokalemic periodic paralysis, and I missed the boat till several months later when I learned that she had suffered with a cardiac arrhythmia, and I was scratching my head, what is happening here? And I was able to share the DNA in this family with Dr. Lou Patachek at that time, and be part of this story of figuring out the potassium channel mutation in Anderson-Tavil syndrome. So what I want to do is kind of give my take on this group of disorders. As you know, a paper that was, I think Dr. Levitt was part of this publication, diagnostic delay of more than 20 years after onset of symptoms. That's often the case with the periodic paralysis. What I found when I was dealing with many families, or some of the families, I wouldn't say a large number, they actually often knew that there was a familial disorder, especially with a genetic disease. And some of the families, and the attitudes may have changed now, were not very ready to admit this issue because the children were in athletics in high school, and they were not sure that they wanted to publicize this condition in the community. So that was one of the interesting things that I experienced. Many patients do get missed. They get told that it's all in their head. But then on the other hand, you have a real problem in the medical field of patients with weakness and fatigue who get, not sure that what it is. Is it periodic paralysis or something else? Now, physicians and patients often have different meanings to the word weakness and fatigue, and these often get interchanged. A lot of patients equate the two. Physicians want the weakness to be paralysis, actual loss of strength in a muscle. Fatigue, I can be fatigued, and yet if a neurologist examines me, I may have a normal muscle strength. So that kind of makes it a little bit harder when you end up in an emergency room or urgent care clinic. Unable to be seen by experienced physician during an attack. And I often ask patients to bring videos of them when they have an attack. So that gives me a little better feel for what's happening with these episodes, because we don't often get to see them. Commonality of these symptoms in an urgent care setting, because many of our patients do end up in the ER during an episode, but there are lots of patients who turn up in the ER with fatigue. I can't do anything, I'm tired, I just, and that makes it very difficult for physicians who are unfamiliar with the disorder to sort this out, because this is indeed a rare condition overall. Now, we've discussed some of the pathophysiology of it at great length, so I don't need to belabor the point. But periodic paralysis is a disorder of the muscle, not of the brain, not of the spinal cord, not of the nerves, not of the neuromuscular junction, but in the muscle itself. You can see a large muscle arranged in fascicles. Within each fascicle, there are these long cells, very long cells. They go from here to here, for example, in the leg. Multinucleated cells, which are covered by the cell membrane. And here is a blow-up of a muscle cell. It's got the contractile proteins within it, and you have an electrical activity that is transmitted to the muscle cell from the nerve through the neuromuscular junction, and then it's translated by a mechanism that we call electromechanical coupling. So you have to turn that electrical impulse into a mechanical message, and these proteins actually slide together in a bridge formation that causes the muscle to contract. The problem in periodic paralysis resides in the sarcolemma, or the membrane of the muscle cell. You've seen these cartoons before, and again, I don't want to spend too much time. There are mutations in the sodium channel, calcium channel, potassium channel, and of course, chloride channel causes myotonia congenita, not periodic paralysis. These are these cylinders, cylindrical proteins stuck on these muscle cell membrane that allow rapid transit of these ions to create that electrical activity and electromechanical coupling. Again, without belaboring this point, you have these muscle cells are negatively charged inside. During an action potential, this negativity rapidly rises to a threshold level. Once it reaches a threshold, you have a all or none. Once it gets here, it is going to act, and this will be conducted along the cell membrane. And notice the timing. This is about 1 to 3 milliseconds, as you can see. And we do know that in almost all of these mutations, you have a problem when the muscle cell gets paralyzed. It does so because it is partially depolarized. I think of it this way. In a normal cell, you need this momentum from minus 90 to minus 65 or 70. This momentum is needed to kick off this action potential. If it is here, the rise from here to here does not create that momentum, and the muscle cell is electrically inexcitable. In all forms of periodic paralysis, the muscle cell membrane is electrically inexcitable. The cartoon again, so what you've done here is cut open the cylinder and spread it out in a flat surface. And again, a cartoon you've seen before. These are the hypokalemic periodic paralysis mutations. About 60% of them are calcium channel, 20% sodium channel. We talked about the arginine residues that seem to be the common factor in these hypokalemic periodic paralysis mutations. The hyperkalemic periodic paralysis mutations involve the sodium channel. And I was quite pleased to hear from Dr. Catterall yesterday that the pore abnormality here is a leaky normal pore. Here it is not through the normal pore, so that kind of makes sense to me that I had not heard of before. And of course, the potassium channel mutation and the Anderson-Tavil syndrome. Now, I think the calcium channel mutations, which underlie hypokalemic periodic paralysis, is a reasonably clean phenotype, does not have a whole lot of complications. There is variability. For example, we know that it is reduced penetrance in females, for example. There's variability. However, in the sodium channel mutations, the clinical picture is quite complex. So if you have a DNA result that says you have a sodium channel mutation, that does not automatically translate to hyperkalemic periodic paralysis. You can have that syndrome. You can have the disorder that we call paramyotonia congenita. The reason it's called paramyotonia congenita is in other myotonic disorders, when you activate the myotonia goes away. Whereas in paramyotonia congenita, the myotonia intensifies with activity for a short period of time. We call it paradoxical myotonia, which is often followed by actual weakness of the muscle. But one of the key features of paramyotonia congenita mutations is that I believe they're cold sensitive. So unlike other people with other mutations, these patients, if they expose the muscle and lower the temperature of the muscle becomes electrically silent. For example, one of the complaints that my family members gave me was that they could not eat ice cream. If they ate ice cream, they could not speak or eat for several hours because the throat muscles were paralyzed because of the lower temperature. Even after you warm up the muscle, it takes several hours for it to come back. There are mutations in sodium channel which gives you a myotonia only, nothing else. This has been called sodium channel myotonia, but this also may go under the name of potassium aggravated myotonia. So just myotonia without paralysis, without cold sensitiveness. And then, of course, you can see hypokalemic periodic paralysis from these mutations as well. And I'm concerned that many patients and families with different mutations, there may be overlap of these clinical picture, if you will. What I mean by that is, even though in the literature, certain mutations are associated, for example, potassium aggravated myotonia are these ones. The hyperkalemics are these, for example, the T704M is one of the common mutations, as is this one here. Paramyotonia congenita. So there's classification, but there's often, you will see in the literature, patients who carry one of these mutations that look like this, or one of these mutations that look like that. So there is that kind of overlap. So the family history is very useful for us. Typically, families are aware of the illness in many and should forcefully suggest this to your pediatrician and to your neurologist, because that'll push them into testing or referring for the appropriate consultation. As you know, these are autosomal dominant inheritance, but in hypokalemics, the females often skip and that can lead to faulty family history. As we know, this is a young onset disease, the genetic forms of it. Typically less than 5 years for hyperkalemic periodic paralysis. In some of the families with paramyotonia congenita, the grandmothers could tell which of the babies is going to get it even within a few months after their birth. I remember talking to them and saying, little Johnny is going to get it, I know it, and they were right. Hypokalemic tends to be more generalized, more severe, lasting a little bit longer, but there's clear overlap between the two types. Of course, the cardiac arrhythmia and other kinds of developmental abnormalities distinguish the ATS syndrome. I find that many patients with hyperkalemic periodic paralysis have focal attacks. I find that many of these patients, and this may be true for hypokalemic as well, I don't have enough experience to say, that even though we call them discrete episodes of attacks, many patients are almost constantly in an attack. If they're sitting still and using their arms to talk, the arms are okay, but when they get up, the legs are weak because they're resting the leg muscle. So you get this kind of a focal, constant type of attack, and this kind of leads into this situation of permanent weakness, and the point that was made that some patients with permanent weakness, some of that weakness is a transient physiological weakness that can be bettered by drugs like Kavase, whereas the rest of the weakness is related to structural loss of muscle cells, which may be more difficult to reverse, if you will. Neuromuscular respiratory failure is uncommon. I have not had that again, but my list of patients is quite small that I follow regularly. We do see a lot of other neuromuscular patients, so there is a way to evaluate these patients if you have breathing trouble and using appropriate measurements and techniques. One can avoid intubation in many patients. So when I hear that somebody is getting intubated multiple times, I worry about it, and certainly some people may need it, but obviously an expert evaluation in that setting is very, very important. Now, I would like to make the point that we talked about the electrical silence of the muscle cell membrane, but that can be picked up on the clinical bedside. And I think this is the key feature of periodic paralysis. Whether it's genetic or acquired, what happens is during an episode of muscle paralysis, the muscle becomes electrically silent. So here is what will happen. If you are normal and you're in the beginning of an attack, and I put an electrode on the muscle and stimulate the nerve and get this wonderful compound muscle action potential, during evolution of the muscle weakness, the response is going to get smaller and smaller and smaller. So you're losing the electrical activity of the muscle. This is the key underlying problem in periodic paralysis. The problem is we don't catch patients during an attack and be able to do this. And if you're able to do this, that settles the diagnosis of periodic paralysis. It cannot be anything else. It can be any type, but it cannot be anything but periodic paralysis. In fact, if I put a needle in the muscle when it is very weak and low in amplitude, normal needle, many of you have experienced it, you hear that funny electrical static noise. The noise will go away because there is no electricity in the muscle. I call it the ghost muscle. So I have examined patients during attacks of paralysis, and I put a needle in the muscle. It's a ghost muscle. It feels like nothing in there. And then it'll come back when your weakness gets better. The long exercise test, which we do in the interictal period, tries to recapitulate this. We bring a patient in, ask the patient to keep the muscle at rest after an exercise period. We often will see this, but it's not 100% sensitive. You may not pick it up in between an attack. So somebody asked about some of the differential diagnosis of periodic paralysis. If you have an episodes of paralysis where there is muscle inexcitability, and the problem is actually to document this by an expert at the time of an attack, it's often hard to do that. It is periodic paralysis. Any disorder with chronic low or even high serum potassium can present with periodic paralysis. So there are a number of kidney disorders, including some genetic disorders that were brought up yesterday like Barter's disease, Gettleman syndrome. These are renal disorders where you will see a change in the urine electrolyte pattern. And interestingly enough, all those are also ion channel mutations, but they affect the kidney rather than the muscle. And the periodic paralysis in these syndromes is because of the secondary problem with serum potassium. In hypokalemic periodic paralysis, actually, during an attack, the urinary serum potassium is actually low. It's not high, because all the potassium is going into your muscle cells. Chronic use of diuretics, chronic use of laxatives can lead to hypokalemia. We don't see barium toxicity, but it has been reported as like a suicidal or homicidal agent. Barium is in depilatory agents, for example. There are other episodic nervous system disorders that are usually clinically easily distinguishable. Episodic ataxia is episodic movement disorders. Cataplexy is associated with narcolepsy, epilepsy, etc. These can be sorted out by a neurologist without much difficulty. Gene testing is most useful in familial cases. So one of the things you want to do if the gene testing is negative, especially if the onset is a bit later in life, you need to look for acquired reasons. You may be running a low serum potassium, which can be adrenal disease, renal disease, or some of these rare genetic renal disorders. In fact, most of those renal disorders come on in early life as well. You see that not 100% of patients have established mutations. We talked about the variants of unknown significance. If clinical picture is diagnostic and you can show that the muscle cell membrane gets shut down during episodes, the VUS is likely to be a real mutation, even though it's reported as a VUS. If clinical uncertainty exists, you need more efforts to establish the clinical diagnosis more firmly. And then there are other research strategies that can be employed to figure out the variants of unknown significance. The other scenario is you have a diagnosis of periodic paralysis, but no mutation detected. The technique may miss mutations in known genes because it's not good enough. Genetic heterogeneity, that is other genes, and we talked about this, for example, the ryanodine receptor, or a disorder other than periodic paralysis. These are findings in patients with potassium channel mutations. This is myotonia, where you grip the hand and you have trouble relaxing the muscle. This prominent myotonia usually seen in paramyotonia congenita, not as much in hyperkalemic periodic paralysis. This is an example of what we call lid lag. This is often the minimum myotonia we see in hyperkalemic periodic paralysis. You look up and look down, and the lid kind of gets stuck up there. Electrical myotonia that is picked up with the needle EMG, as you can see there. I think if you have a sodium channel mutation, your phenotype, the geneticists like to use the word phenotype. Your clinical picture has to be carefully analyzed. Is it periodic paralysis? Is it a cold-sensitive syndrome? Is it a sodium channel myotonia? Because your management can be a little bit different. We have an example here of one of my patients who would come into the hospital with focal attacks of intense myotonia. The muscle will be intensely active, stuck in a position, very painful, and I don't know whether correcting a potassium or anything helped her. In fact, we tried anti-myotonic drugs rather than the routine. Her potassiums were normal at the time. I'm sorry this doesn't show well, unfortunately. This is, so what I'm showing here, if you can see it, is we begin the muscle in a normal temperature. Somewhere along the way, we cool it, and the response becomes delayed because it is cold, but it also falls off in amplitude. This is another patient. And so this is cold sensitivity. That means when you cool the muscle, the response, some of the muscle cells are becoming inexcitable. This is rest after exercise over a period of 30 minutes. The response becomes smaller and smaller again. So this kind of phenotypic analysis often helps us to manage the patients a little bit better. And I was struck by the non-muscle symptoms, and I just wanted to be curious and look this up. So you can go to the database and show where these channels are expressed, for example, and it turns out that the potassium channel that's mutated in Anderson-Tavel is expressed widely, which goes along with the wide phenotype, that wide clinical picture, the skeletal deformities, the cardiac problems, et cetera, that you see. Whereas the calcium channel and the sodium channel are expressed predominantly in skeletal muscle, a little bit in other tissues as well. Here, for example, I think there is expression in the genitourinary system in females. So the question is, this would suggest anyway, that some of the extra muscles clinical picture we're hearing about may have a secondary origin rather than just in the mutation itself. I will briefly summarize this, but I think you folks are more familiar with this than I am because you work out methodologies that I don't know anything about and how you deal with some of your symptoms because I'm not there with you every day that you get. If you're cold sensitive, keeping the muscles warm may be one way to get rid of a myotonic attack or even paralysis of a focal nature in potassium channel mutation. We talked about the mild warm-up and the warm-down yesterday. In fact, I had one slide showing the drop-off in the muscle potential. I couldn't dig it out of my folder, where I told the patient to keep on gently activating the leg. And what we saw was that we could avoid that drop-off that was present when the muscle was totally at rest. If you gently activated the muscle, the response stayed up. So gentle activity certainly helps many patients with periodic paralysis. We talk about, giving potassium, usually short-acting variety for acute attacks. Carbohydrate snacks can avoid an impending hyperkalemic periodic paralysis attack. Salbutamol, which is Ventolin, which is a beta agonist, it works on the adrenergic system, probably drives the potassium into the cells for hyperkalemic periodic paralysis. People brought up propranolol yesterday. I don't have any experience with propranolol, but I remember an old paper where when people could do these very intensive studies, Dr. Andy Engel from Mayo Clinic reported that if he injected a norepinephrine or adrenaline, one of the sympathetic catecholamine drugs, regionally into an arm or a leg with a patient with hypokalemic periodic paralysis, that leg will get paralyzed. He reported this. Of course, we cannot do these studies anymore. The IRB is not going to let us do those kind of studies anymore. But I do recall that there is a direct effect of these hormones, which you usually generate in response to stress. If you put out too much of those hormones, it's going to depolarize your muscle cell, make them paralyzed. The same with insulin. You can actually take a muscle cell from patients with hypokalemic periodic paralysis in a bath and squirt a little bit of insulin. That's going to paralyze it. So you can imagine when you eat carbohydrates, you're increasing your insulin level in response to that, and that probably explains these acute attacks with carbohydrate snacks, if you will, in hypokalemic periodic paralysis. The problem is the homeostasis, the precise nature in the body controls these catecholamines, insulin, sugar level, electrolyte levels. It's not going to keep it at a very constant level. And what I find in many patients is, in terms of serum potassium, each patient seems to have a sweet spot where they do well. And I'm not sure that it's easy to keep it at the sweet spot all the time. I do consider anti-myotonic agents if I think that a patient with sodium channel mutation has more myotonia than periodic paralysis. They often get into episodes of myotonia where they get very stiff, very painful. And if you don't see them during that, it's hard to figure that out. And again, I think this is things that are quite familiar with, and I won't go into that. Talked a little bit about special situations. During pregnancy, there is both increase and decrease in rates of attack that different people have reported, which also kind of dovetails into issues of anesthesia, which were brought up yesterday, so I thought I'd put it up there. And like many things in this rare disease, and I've dealt with other rare disorders where I've been part of care guideline committees where we try to develop. In many of those rare disorders, we did not have what medicine calls evidence-based recommendations. Nobody has done large-scale studies to say, this is how you need to do this. So it also, often these guidelines that we put out for these disorders have been what we call consensus-based care guidelines. So people who have taken care of these patients, experts are brought together, discuss the details, and pull together certain care guidelines. And that may be important for this group to do as well, bring people together to pull out what we call consensus-based care guidelines. And some of the common things we see with anesthesia and neuromuscular disease, obviously lung function. In many other disorders, the lung function is predictable. It predictably goes down as they get weaker. So we can tell before anesthesia and surgery, how good is it? Does it need to be managed? The problem in periodic paralysis, of course, is you can start with a normal lung function, breathing muscles before the surgery, but during the surgery, you develop hypokalemia and you lose your strength. So that's a problem. So but it can be managed. cardiac clearance with those with cardiac issues, making sure that if they have a cardiac rhythm problem, that is appropriately managed by a device. In some of the other disorders like that I take care of, like myotonic dystrophy, many of our patients have a prophylactic defibrillator and pacemaker put in, and the cardiac device has to be checked out before anesthesia and surgery. In any of these muscle disorders, particularly those that have myotonia as a part of it, when you use certain drugs like succinylcholine, which are depolarizing drugs, you may get an unusual myotonic reaction. The muscle may become intensely stiff, which the anesthesia person may not expect. And that often causes trouble with intubating and relaxing their muscles and leads to an unexpected problem in the anesthetic table. So generally, and again, there are no guidelines for this particular group of diseases, but I would say avoiding non-depolarizing drugs would be important. And the issue of malignant hyperthermia, of course, malignant hyperthermia is usually related to ryanodine receptor mutation, which is a cause of atypical periodic paralysis. So you always worry about malignant hyperthermia in any kind of muscle disorder like this. I don't know whether there's an excess of MH in this population, but anesthesia people need to be aware of your muscle disease and the potential for malignant hyperthermia. It's usually triggered by halothane type of anesthesia. May want to avoid those things. And of course, in this particular disorder, they need to watch your serum potassium and electrolytes very carefully, pre-op, intra-op, and post-op, and temperature, because again, many patients are cold sensitive. A lowered body temperature is going to make the muscle paralyzed. And the anesthesia people need to be aware of it, because during surgery, often your body temperature will go down. So they need to maintain the body temperature, will all be important. And I want to thank you for your patience, and I'm happy to be in here and happy to help in any way I can. Thank you.
That was really excellent overview. Are there any questions for Dr. Subramony? I'm sure there's a bunch. I have one also, and maybe while Steve is here too. There are some folks who, get paralyzed, and I believe clinically have periodic paralysis, and they go down, sometimes suddenly, and they're paralyzed, but then they twitch or jerk, which doesn't make any sense at all, because if you're paralyzed, you shouldn't be able to twitch. You should be paralyzed, but yet, they're twitching. Do you have any hypothesis, comment?
No. I mean, certainly the sodium channel mutations seem to swing between excess muscle activity and little muscle activity. That doesn't seem to happen in the hypokalemic periodic paralysis, because you don't usually see myotonia. But with regard to that particular symptom, I have no clue.
Okay, I just throw it out there. Here you
go. Okay, what I wanted to ask was, like I like to do a lot of exercise, but I know I shouldn't overdo it. But the exercises that I'm trying to do to keep muscle with the periodic paralysis, is it helping to keep my muscles from just atrophying and eventually I'm not going to have any muscle there? Or is it where the exercises that I'm doing may prevent it from happening?
Good. Dr. Levitt, can you repeat that question?
Yeah. Sure. So I guess the idea is that if you don't exercise, your muscles are going to atrophy. And if you exercise, you're going to get paralyzed and have your muscles atrophy. How do you keep physically... Right. Is the exercise helping or is the exercise harming? How do you keep physically fit with this disease?
Difficult question. Of course, in general, with many muscle diseases, not specifically with periodic paralysis, we say do not exercise to a point of crampy, achy muscle. Now, having said that, I think the periodic paralysis, just thinking about it, a unique situation. That again, going back to my comment about serum electrolytes, there may be a sweet spot of exercise for different people, because when you activate your muscle, you are pulling that sodium in and pushing the potassium out. You're getting these changes all the time, and you do have a leaky sodium channel, and it's very likely that the permanent weakness that you have results from the excess leak of sodium into the muscle cell and secondary problems that happen within the muscle cell. So you could argue, and again, there is no way for me to give you a judgment on this regard. We also know that mild warm-up keeps many patients from becoming significantly weak. So I would say a moderate amount of exercise, maybe more frequent, not intense in short periods of time, may be a useful thing rather than, like many of us do, go to the gym for 1 hour and sit down for the rest of the time. Others may have opinions on this. I see some hands maybe. And so that's just a guesswork on my part.
It's great. There's a lot of hands, so we'll get to everyone. Just write down the question if you forget.
Thank you for your information this morning. My wife was diagnosed with hypo in '94. Has been on Diamox and potassium since that time. 2 questions. One is about 10 years ago, she developed a chronic cough that has been almost as debilitating as the paralysis itself. So I wondered if you had any thoughts on that, or if anyone else has experienced anything like that. She does not cough during episodes, so it goes away during a paralysis episode.
Does she have a sodium channel or calcium channel mutation?
It was a clinical diagnosis.
Okay.
So we have she's not been tested yet.
I mean, as a person having dealt with a lot of genetic disorders, I keep an open mind, because we sometimes find a clinical thing that we did not expect after we find the mutation. I don't know the answer again. I mean, there are, of course, the common things that general physicians think about, postnasal drip and other types of lung disorders and exposure to allergens and smoke. If those are excluded, there are certain medications that can give you chronic cough. You need to be sure that you're not on some medicines that are inducing that cough. Reflux from the stomach can give you a cough. So I'm just talking about things that are not part of the periodic paralysis. I was intrigued by a report with one of the sodium channel mutations. There was a patient with maybe more than one, what they call fatal neonatal laryngospasm. There was a very severe phenotype in a baby where the baby developed spasm of the throat, for example, which was made the patient very sick, and I don't remember that particular mutation. So is it possible that some of these mutations have things like, when I look through that expression pattern in various tissues, you do see a minimal expression in other tissues other than muscle. Maybe that's enough to change something in the bronchial tree. I don't know. And no matter what, this will obviously need to be dealt with in a symptomatic fashion.
Okay. The second question I have was on the ability to measure potassium at home. Has there been any progress made in that area?
I don't know. Dr. Levitt may know better than I mean, you know, that we still have that iStat thing that is used in hospital settings, in surgical settings, but so far not great. I'm not a big fan of the home ion meters that were meant to test, water or like soil, and you spit in it or put your blood in it and measure potassium. I think that's very dangerous to use because it's not calibrated, it's not FDA approved, and if you get a wrong reading and act upon it, it's kind of dangerous. People do that at their own risk, but so basically no, the short answer.
It was about the previous question about how can you have jerking if you're paralyzed. I found that before I got treatment for paralytic paralysis, I had myoclonic jerking in a severe degree. I had, just an example, I had Now I only have it when I have an attack and in a smaller degree, and I found out it has a lot to do with my the strength of breathing. So 2 days ago I had an attack out here, and I quit breathing completely when I have an attack often, and at one point I was totally gone. There was no reflexes. As I started getting better, I started jerking, and there was a couple of paramedics there, and I said, "It's okay, it's a good sign," because that's when my muscles start working again. And I've seen this in the hospital. When I've been completely paralyzed, I have actually, they've actually proved I have no reflexes, but it might only be for a minute or two. And then when they try again, I have a little bit of reflex. And that's when the jerking starts for me. So I didn't know how bad my breathing problems were until I was assessed. I've been fortunate enough to have Dr. Weber in my case, so he suggested I go to a respiratory doctor, and found out that even on a good day, my, what's it called, the CO2, what is that in Danish, or English, sorry? CO2, that it was so high that I should have maybe been on the way to a coma. And actually I was walking around breathing. They don't understand that I could walk around with so high CO2. My oxygen level was like 92, so they didn't understand that. But it's definitely the jerking. On top of that, I also had a D vitamin deficiency and a magnesium deficiency. I only get it now, the jerking, when I'm in a bad attack and I don't breathe well.
That's interesting. That probably gives people some ideas. I mean, maybe the muscles are flipping in and out of complete inexcitability.
I just had a comment about exercise. I'm an exercise physiologist, and we've, in the lab that I was working in, we've done some research with spinal cord injury patients and passive movement. So sometimes even if you are not physically able to move, having a caretaker, spouse, child, whatever it may be, there's still benefits that you can get to circulate blood flow and things like that to the muscle that can help. Just with overall blood flow and all that sort of stuff, and helping to clear out some of the metabolites that build up, even if you're not physically able to exercise. And then I've also personally worked with a number of people with different chronic and rare diseases as like kind of helping them train and exercise. And the main recommendations at this point are, if you have a muscle condition, you don't work out to the point of muscle breakdown, like a lot of people would say to do to build muscle. You work out up until you would get to that point, because you're going to get the benefit of movement and maintaining without that breakdown of the muscle that is going to be detrimental in the long run.
Like weightlifting versus, walking.
Yeah, so like if you wanted to do like weightlifting, it would be lighter weights. You're talking more kind of the muscular endurance, not looking for hypertrophy or building actual muscle, bodybuilding. Cardio exercise or stuff where you're working below that threshold of I'm gonna die sort of thing. You want to stay well under that. And I'd be happy to talk to anybody if you have any questions. I don't know everything. I'm newer to periodic paralysis. I've only been diagnosed for a year and a half, but I've had symptoms for a while, and I've worked with a lot of people with different types of chronic conditions. And so I have the black poodle. Come say hi if you have any questions.
Very cute. Been petting him.
Hi, our questions come based on breathing episodes, or breathing difficulty due to full body paralysis. My husband didn't used to have that when it first started, and now he does, and it seems to be getting worse. His breathing gets very, very shallow and it slows down. My concern is, does anybody else have this situation? Does it continue to get worse? Yesterday after the conference, we were talking to some of the paramedics, and one paramedic brought up, well, does he have a gag reflex? And I don't know, I don't stick my finger down his throat when he's paralyzed. But he said if he's conscious, which they are, we are, and he has a gag reflex, doing like emergency breathing for him won't work because has that gag reflex. So I just am curious if anybody else has had any experience with that. And then also, since his breathing has gotten more affected, when he starts coming out of it, he does have his right arm that does twitch now as he's recovering.
So, I mean, muscle weakness and respiratory, what we call restrictive lung disease, is quite common in many progressive muscle disorders. Now, again, periodic paralysis is unique because in other disorders you have a predictable slow decline in diaphragm function, in the chest wall function, depending on what the disease is. And it's a little bit easier to make recommendations. We follow the pulmonary function. In many disorders, we have a poor cough, so we measure something called peak expiratory cough flow to see how good a mechanism cough is, because it gives us an idea how forceful the cough is. And many of our patients, actually, the cough may become depressed before their respiratory muscles lose their strength. And we make recommendations of how to keep your chest clear of secretions, because with these kind of symptoms that you're talking about, there are a couple of risks. One is a higher risk for chest infections. If you get a little cold, pneumonia will be more easy to occur if you're not clearing your secretions and if you don't have a good cough. And of course, if you end up having a lot of respiratory muscle weakness, typically the carbon dioxide level goes up, as somebody just pointed out, before the oxygen level goes down, makes you tired, you have poor sleep. A lot of times we recommend sleep studies now to see what they're doing at night, because some of these patients with muscle weakness in the chest wall, the initial problem is with sleep. They will desaturate, their oxygen level will go down more than normally if you have respiratory muscle weakness in a sleep study. And in some places, we also can monitor the carbon dioxide because CO2 tends to go up during the night. You wake up with a morning headache and have excessive tiredness during the day. So those are some of the symptoms of neuromuscular respiratory deficiency. The problem that happens with periodic paralysis is, of course, the intense swing. Some day you may be totally normal, other days you're up and down. Then, of course, then you have the progressive patients who have progressive weakness who can fit into the mold that I just talked about. So if it's a periodic, comes and goes sort of thing, I don't know the best answer, but again, a good pulmonologist or a neuromuscular physicians increasingly take care of the lung issues that happen in muscle diseases. We have, for example, the capability of measuring the respiratory function in our clinic. We do that as a routine when patients come to see me to see what their breathing muscles are like. Pulmonologists will be able to do other things like measuring carbon dioxide and oxygen. We sometimes have home-based oximetry to see what happens to oxygen at night. So there are lots of things available in the absence of a direct treatment to improve everything in a genetic disease like this. And those can be managed. And there are increasing non-invasive techniques to manage respiratory failure without intubation or tracheostomy. So these are available, and it's the important thing is to find the right group of people who can help you with those and see if they cannot understand the symptoms and do the right thing.
Yeah, there's a lot of commentary on this. I'm going to try to get to everybody.
Okay. I have the same problem, but in a very severe way if I am awake. I do not have it when I sleep, the apnea, but I have apnea when I'm awake. And I discovered something. I get medical exams for it soon. There are medications to, what is the name of it? Stimulate the breathing muscles from the brain, like Mestinon, Prozac, 3.4 DAP does that also. But now I discovered some food issues for me. That's not a problem in everyone I know. But yesterday there was a man and he said, when I'm very weak, I take a cold shower. I don't know if he's still here. No? Oh, but I have that as well. So if I breathe very difficulty, I have very difficulty to breathe, then I have to take a cold shower and it's okay. But if I warm up, my body temperature is always a little high, then the breathing problem starts again. So there's more than only periodic paralysis, but congenital myasthenia syndrome does the same, give the same problems, and porphyria is something they will look into for me and give these problems even more. So.
And then what do you think about the role of like having a home pulse oximeter and maybe even like a bag mask if someone is very frequently, going down and has very shallow breathing and stuff like this? Is that a...
Right. I mean, if there's a consistent decrease in desaturation during the night, for example, or CO2 rise, many of our other neuromuscular patients are on non-invasive ventilation at night. Depending on what kind of breathing abnormalities they have, it can be a CPAP or a BiPAP, something called Trilogy. These are machines, a lot of people are using it anyway without neuromuscular disease because they have obstructive sleep apnea. I've got one in my room and I cannot sleep without it. But there are many of these machines available that will help you with that. It's not been our experience with any of the muscular disorders that, except for some very bad ones like Duchenne and ALS, that these patients need daytime assistance. Some of them do, but some of the really severe neuromuscular respiratory failure may extend the time from night to day. So yes, appropriate evaluation, understanding what is happening, is it obstructive, is there sleep apnea, is it neuromuscular respiratory failure, will allow for proper management. There is also, for example, we have a group of pulmonary physical therapy research faculty, a couple of them, that are trying to understand the role of respiratory exercise and breathing exercise in improving pulmonary function and swallowing function. And they come up with innovative methodologies to try and help patients with these kind of problems because, the role of non-pharmacological intervention in many of these disorders is quite important. And the thing I like about non-pharmacological intervention, you don't have side effects. So I'm very much in line with that. If we can help breathing with breathing exercise, cough exercise, chest percussion, all those things. So we have pulmonary physical therapy people who work on those with some of our patients to try and help them. Again, it's a very individualized decision that you work out with an expert if you can.
Our family has paramyotonia congenita. I have a 34-year-old daughter who has respiratory issues during episodes.
Mm.
She never started the full body episodes till she was in her 20s. And as time went on, it did start affecting her respiratory. And in fact, it seems to attack her respiratory first when she goes into an episode. She's seen many, many doctors. She's spent the last few years basically in the hospital. She does not have any lung disease. It's just during the episodes, her oxygen can go below 80. She feels everything in her diaphragm, in her throat muscles, and until she comes out of it, that's the way it is.
So
yes, she's been intubated many times, and I can stand there and say, please don't intubate her, and they'll say, she's not breathing on her own after they've begged her for many minutes.
So this is you have a sodium channel mutation?
Yes, SCN4A,
Yeah.
T1313M.
Yeah. And again, so this is a paralytic episode rather than a myotonic episode, I'm assuming, or it's hard to tell sometimes. Is it muscle stiffening up or is it muscle becoming weaker? Could they?
I'd say it was both, everything.
Right.
Yeah.
Well, no matter what, I mean, I think, again, in this situation, I would apply what we do with other similar disorders, and She okay?
Are the paramedic guys here? Or?
So to continue my comments about acute problems, generally in many of these patients, we will monitor their respiration. There are certain numbers that we generate, like vital capacity, negative inspiratory force, blood gases, and there are certain guidelines people generally follow. Say if the numbers get below a certain level, you worry that they will need to be intubated. So those guidelines generally come from not periodic paralysis, from other disorders. So muscle weakness leading to respiratory failure, there are these guidelines that have been developed from other disorders. For example, if you look at patients with myasthenia gravis and Guillain-Barré syndrome, 1 in 5 of those patients end up needing to be on a ventilator at some point in the course of the illness. So there are some guidelines that were developed because these patients gradually decline in front of your eyes in the hospital. So there are those guidelines that we kind of tend to follow in any patient with muscle weakness, a negative inspiratory force of -25. If you're not going to generate that degree of inspiratory force, you need to be in an ICU. 22 per kilogram or something like that, vital capacity, ml per kilogram, then, when I was younger in training, many of these patients, not periodic paralysis, such as other muscle patients, would often get intubated in an emergency situation, and we avoid that. We do prophylaxis, but only if it's needed. And the non-invasive ventilators have become quite useful, even in many of our patients avoid, even with myasthenia gravis, by using these non-invasive machines. So what Dr. Levitt was talking about, having a mask at home, that's kind of these machines basically put a mask on your face and be able to generate pressure. So I don't know what to say about that particular patient who has repeated episodes of significant respiratory problems, other than being able to manage that and also at the same time manage their attack with lowering the potassium, salbutamol, whatever, and glucose infusion, whatever it takes to bring the potassium down and allow the paralysis to get better. So I'll stop there with that. All right, thank you very much.